Good morning, everybody. My name is Catherine Morris, and I will be speaking to you about fibrosing mediastinitis secondary to histoplasmosis for this grand round presentation. So I hope you enjoy. So our learning objectives will be understanding fibrosing mediastinitis secondary to histoplasmosis, the case study that I found interesting during my clinicals, clinical recognition, diagnostic approaches, multidisciplinary approaches, treatment modalities, complication management, and patient education. So what you'll see on a good amount of the slides are x-rays, and these are all x-rays from our case study. As you can see that the heart is very enlarged, that's the mediastinum, and it's reaching out to the left side of the chest wall. And then you can see up in the top left is a little bit of pulmonary congestion, and bottom right you can see tiny little fibroses, which I will discuss in the slides to come. So histoplasmosis leading to fibrosing mediastinitis. Histoplasmosis is an infectious disease that occurs when an individual inhales airborne spores of the fungus, commonly found in soil enriched with bird or bat droppings. In some cases, the immune response to the infection triggers an exaggerated fibrotic reaction, leading to fibrosing mediastinitis. Histoplasmosis is an infectious disease caused by the fungus Histoplasma capsulatum. It can present as an isolated pulmonary infection with or without mediastinal involvement. Obviously, in this case, there is mediastinal involvement. Common manifestations include flu-like symptoms, respiratory issues such as cough and chest pain, and in severe cases, dissemination to other organs leading to weight loss and organ enlargement. And that is by Manuruki et al. 2021. In this case study, the patient was diagnosed in 2021, and this disease process has developed into fibrosing mediastinitis after years of chronic histoplasmosis. So fibrosing mediastinitis is a rare condition characterized by excessive growth of the fibrous tissue in the mediastinum, the central compartment of the chest containing vital structures such as the heart, great vessels, esophagus, trachea, and thymus. So the pathophysiology and physiology of histoplasmosis. H. capsulatum produce asymptomatic or subclinical disease. There is a local spread to regional lymph nodes and or throughout the reticuloendothelial system, as shown by small fibrotic and calcified granulomas, commonly discovered at autopsy. It is a rare disease to diagnose, and it mostly isn't found until autopsy, but luckily for this patient's case, he was diagnosed 11 years ago and has been dealing with it chronically since. So according to Demkowitz and Prokop, Histoplasmosa capsulatum yeast, they are characterized by their small size, lack of capsules, and consistent sizing. Budding results in a narrow-based monopolar bud. Histologic features of histoplasma granulomas include necrotizing or non-necrotizing stages, with the natural progression form, active granulomas containing infecting yeast to subsequent proliferations of the fibrous tissue. So basically, it takes over the entire lung, causing necrotitis in those tissues by the yeast. This continues until the lesions consist solely of central residual caseous necrosis surrounding by a well-developed fibrous tissue rim and then associated lymphocytic cuff. Advanced fibrotic lesions show non-viable leads from bases based on culture and molecular evidence. So if you look at this x-ray, which is an x-ray of him, as I said earlier, if you look at the bottom left corner, which will be his right lower lobe, you will see these small capsules here and throughout his lungs, and this will be the budding yeast. They're consistent in size, small and circular, but these are the small fibrotic and calcified granulomas. They do spread throughout all of his lobes. And then there is some pulmonary congestion over here, along with some of the small fibrotic and calcified granulomas, but this ends up turning into a pneumonia on his upper left. So this case study, the patient presents to the emergency room, 32-year-old male, complaining of syncope in bed, productive cough for 2 days, producing yellow and blood-tinged sputum, palpitations, nasal congestion, chest pain, and shortness of breath. He was put on 6 liters nasal cannula with an O2 saturation of 95%. The chest x-ray and CT chest showed right middle lobe atelectasis, left pleural wall thickening, and worsening bilateral lung infiltrates. Patient was pan-cultured, started on broad spectrum antibiotics, and was also diuresed. So these are the patient data specifics. He has an extensive past medical history of cardiac issues plus respiratory. He has chronic hypoxemic respiratory failure, elevated bilirubin, fibrosing mediastinitis secondary to histoplasmosis since 2011, hemoptysis. He was on anticoagulants, but he had to discontinue those because of the hemoptysis. History of pulmonary embolus, left ventricular dysfunction, non-rheumatic tricuspid valve regurgitation, pulmonary arterial hypertension group 5 since 2012, pulmonary artery thrombosis, pulmonary stenosis, and he has received inotropic medication, right ventricular dysfunction, and right ventricular failure, along with syncope. He has no known childhood illnesses. Adult illnesses are listed as above, and he has had 3 heart caths in the past 4 years. His health maintenance: patient was living in Colorado. He now lives in Los Angeles with his aunt, and if approved for the transplant, his mother will move to LA to care for him. He has been on disability for the last year and has a 7-year-old daughter back in Colorado. There is no family history on file, nor did they disclose any throughout this case matter. In his social history, he is a single male in LA living with his aunt, a former cigarette smoker, has not had a drink in 2 years. He dabbled in marijuana and cocaine in college and has a 7-year-old daughter living in Colorado. Occupational and educational history are not on his file, and as I mentioned previously, the mother will move to LA if the patient receives the heart and lung transplant. So, clinical recognition. Typically, affected individuals are young and display symptoms associated with the blockage of crucial mediastinal structures, including the esophagus, airways, pulmonary arteries or veins, and central systemic veins. Common initial complaints involve cough, difficulty breathing, coughing up blood, and sharp chest pain. Hemoptysis, or the coughing up blood, can occur in 20% of the cases and has various potential causes in individuals with fibrosing mediastinitis. And that's also by Manyaruki et al. 2021. And these are the symptoms that this patient did present to the emergency department with. Next. No, one more. Yeah, so this slide may be a little bit out of order with complication management. These complications can arise pre-transplant and post-transplant, such as respiratory acidosis. For respiratory acidosis, it might be something brewing in the lung cavity, so we'll get a bronchoscopy. We'll send a bowel for sputum cultures. We'll grab serial ABGs and then change the vent settings accordingly. And we'll add a pulmonary toilet such as Medanebs, Duonebs, Mucomist, sometimes chest CT and physiotherapy. A lot of times they have fluid overload and depressed RV function, so typically we'll start them on CRRT, which is continuous renal replacement therapy, or continuous dialysis. It's much more easier on the body and on the systems post-transplant. We'll do inotrope titration, such as dobutamine, epi. We'll add diuretics, albumin if needed. Obviously, we're going to be monitoring those I's and O's and taking daily and as needed chest x-rays just to monitor if the chest and lungs are looking any more fluffier, if there's any more fluid in them, etc. And of course, both ways, pre and post, they will be in some pain. So we're going to do our best to add a multimodal pain med such as, lidocaine patches, Tylenol around the clock. We'll add Robaxin, gabapentin. Most likely they'll be vented, so we will have a fentanyl drip, and then either propofol or Precedex for sedation just to help calm them down. Movement is so important in recovery, So we'll do passive range of motion with them if they're unable to do active. If they are able to do active and participate more so in their care, we will do our best to get them up to the cardiac chair. Obviously, rejection is post-transplant. So if we are seeing signs of rejection, we'll see them through monitoring labs such as procal or procalcitonin, lactic acid. We'll see fevers. So we'll either add another round of thymoglobulin to help rid the killer T cells, increase their immunosuppression medication such as Tacro or Cellcept. If severe enough and able to, we would retransplant, but mainly just monitoring those medication levels. A few other issues could be pleural effusions and pneumothorax. And if all of these do arise, they will most likely be needing prolonged mechanical ventilation management along with inhaled nitric oxide. So looking at these x-rays on the screen, the bottom right, this is immediately post-transplant, and you can see that by the packing over here. If you notice, we still have a little bit of congestion in his lobe up here. You know what? I'll tell you now. I'll ruin the surprise. So his donor lungs actually had Legionella in them. So not all transplant donors are clean organs. He did end up getting Legionella. But if you look at the bottom right lobe, you don't see any more of those fibrotic capsules or the budding yeast. So good news. If you look on the if you look on the top, you can see the outline much better of his mediastinum, and his heart looks normal shape. It's not going up the chest wall over here. So if you can see the diameter, it's not touching this wall right here. So that's great. You can see some of the management we've done. We have put in chest tubes. So he has bilateral pleural chest tubes that are here. I'm not sure you see the left one. We have a Y mediastinum chest tube that'll come down here. Oops, got a little out of the way. This is looking like a Swan-Ganz catheter, helps monitor our fluid balance and our coaxes. He has the ET tube right here. And I'm not quite sure what this is. Oh, you know what? It looks like it's one of the Salem sumps for feeding or gastric decompression. But as you can see, he is lined up post-transplant. And those are just some of the modalities that we use. So this patient is going to come across almost every team in the hospital, just because we're going to use all these interdisciplinary teams to help come up with the best care plan possible for the patient. These teams include cardiology, pulmonology, infectious disease, obviously our cardiothoracic surgeons, transplant specialists and coordinators, immunologists, a huge playmaker for both a liaison between the patient and the surgeons and the doctors and insurance companies are social work and caseworkers. They're fabulous. Physical therapy, sometimes occupational and speech therapy, depending on the severity of the course. And then our amazing teams of nurses throughout the cases. So the goal is to address the diverse aspects of the condition, and we're considering both the underlying histoplasmosis infection and the fibrotic changes in the mediastinum. So here are some of the key components of the multidisciplinary approach to the plan of care. So basically, post-transplant and pre, the patient will be on the cardiothoracic ICU, and that's who will be managing the patient for most of his stay. The orthotopic heart transplant and bilateral orthotopic lung transplant will be through cardiothoracic surgery, and they kind of have the final say in everything that happens. So everything that the CTICU team does is going to be ran by the cardiothoracic surgery team first. The patient will be on immunosuppressive therapy And that's where the transplant team and pharmacy comes in, just to make sure it's the right dose, right med, getting it at the right time, monitoring those appropriate levels. The antivirals will be on antibiotics, and antifungals will be infectious disease and also pharmacy for the reasons listed above. Pain management will be CT surgery and the CTICU team. The renal failure and fluid overload, RV function aspect, will be placed on CRRT, who is managed by nephrology. And then sugars are so important post-surgery, and mostly because of the steroids they'll be receiving as one of the treatment modalities. So they'll get steroid-induced hyperglycemia. Almost every patient is put on an insulin drip post-surgery, and that's monitored by endocrinology. We, of course, have the orders to follow out on the CTICU for those nurses managing and the teams and residents and nurse practitioners consulting, but endocrine manages that. Dietary for the patient's nutrition. We want to make sure we're promoting healing and feeding the patient through either a post-pyloric tube or a Dobhoff, but we prefer post-pyloric. And then once the patient is stable, is able to move and participate in their care, we're going to get physical, occupational, and speech therapy involved. And then one of the largest aspects is insurance. And case management and social work at Cedars are absolutely phenomenal. Just within speaking with the patient, finding everything they need, working everything out with Medi-Cal, and just things like that. As we say, it's a lot of interdisciplinary teams and multidisciplinary plan of care that all comes together in the end to make sure we have the best outcome for the patient. Now we have treatment modalities for fibrosing mediastinitis secondary to histoplasmosis. And although most commonly manifesting with flu-like symptoms, mediastinal manifestations, including adenitis, granulomas, or fibrosing mediastinitis, are all potential complications that can lead to obstruction and compression of the mediastinal structures, requiring the need for surgical interventions. And that is by Katsourbas, 2022. And unfortunately, this patient is one who did need surgical interventions. And those surgical interventions that I'm going to be talking about on the next slide will be his heart transplant and bilateral lung transplant. Others are corticosteroids, immunosuppressive therapy, symptom management for the flu-like symptoms in the beginning, bronchoscopic interventions, antifungal medications, pulmonary rehabilitation, and then just long-term follow-up care for life, more than likely. So the treatment of fibrosing mediastinitis secondary to histoplasmosis involves a combination of all of this medical management and surgical interventions. The goal is to alleviate symptoms, manage the complications that I talked about on the previous slide, and then hopefully improve the patient's quality of life. So the oral antifungal medications is often used to treat active histoplasmosis. It helps control the progression of the fungal infections and may be prescribed for an extended period of time. The corticosteroids may be prescribed to help reduce inflammation and manage the symptoms. However, the use of corticosteroids needs to be carefully monitored due to the potential side effects and the risk of immunosuppression, along with the risk of hyperglycemia, as I also spoke about in the last slide. Immunosuppressive medications may be considered to manage the inflammatory response associated with fibrosing mediastinitis, and it could also help reduce fibrosis and improve symptoms. In the cases where airway obstruction is a significant issue, bronchoscopic interventions such as bronchial dilation or stent placement may be considered to relieve the obstruction and improve airflow. Other than that, we've talked about symptom management on the other slide. Pulmonary rehab will be just getting that whole pulmonary toilet that I talked about with the Medanebs, Duonebs, Mucomist nebulizers, chest physiotherapy, and then just really using that incentive spirometer while they can, pre-surgery and post. And then follow-up care is going to be lifelong, and it's going to be with his pulmonologist, it's going to be cardiology, it's going to be physical therapy. He's pretty much going to see everyone. Because of how severe the patient's diagnoses is, surgical intervention was required. So they did a orthotopic heart transplant and bilateral orthotopic lunge transplant. We call them OHT and Bolt. So the first part of receiving or even being on the up for listing to receive an organ is recipient evaluation and donor matching. So for recipient evaluation, candidates undergo a thorough evaluation process to assess their overall health, heart and lung condition, and suitability for transplantation. And then they go through donor matching. We'll touch base a little bit more on recipient evaluation. They'll have to be signed off on cardiology, pulmonology, casework. They'll have to go through insurance, where case management will help. For this patient, they had to live in the state of California for at least 6 months to be able to apply for Medi-Cal insurance, which he did do. In the beginning, I mentioned that he did live in Colorado, but he's now living with his aunt in LA in order to receive this transplant. So now he has Medi-Cal insurance, and they are covering some of the transplant. Next, once they're listed, we have donor matching, and that can take, oh boy, it can be quick. They can be very lucky and receive an organ that matches them right off the bat, or it can take weeks to months to no one knows how long. So donors are obtained from individuals who have consented for organ donation, and matching is done based on factors such as blood type. Size is a huge issue, especially if they're doing both a heart and lung, as well as tissue compatibility. So for the heart transplantation, surgical technique. So the recipient preparation is the recipient's heart is removed while leaving the atria intact, and the donor heart is prepared for transplantation. So they kind of clamp, they put them on bypass just to keep everything else flowing, and then they'll remove the heart. They will do vascular anastomoses. So the donor's heart, major vessels, aorta and pulmonary artery, are sutured into the recipient's vessels, and then the atria are connected. Ischemic time is, we want to reduce as much ischemic time as possible, so it's like downtime. So minimizing the ischemic time is crucial because it preserves the donor heart. Techniques like cold preservation and in some cases machine perfusion are employed, such as bypass. So if there are more like post-op complications or like post-surgical complications such as oozing and bleeding, a lot of cases they'll check back on the ischemic time, and if it's a longer time, they're like, oh, that makes sense. There's more reasons to go awry if it's the ischemic time is prolonged. So then the lung transportation surgical technique. The recipient's damaged lungs are removed and the donor lungs are implanted. Vascular and bronchial anastomoses are performed to connect the new lungs to the recipient's circulatory and respiratory system. Complications of both transplants is infection is the number one, which is why we have prophylactic antibiotics such as Ancef is typically our go-to along with Vanc. But immunosuppressive medications increase the risk of infection, particularly in the early post-transplant period. So they have been on all these immunosuppressive medications prior to, and now they're going on them post-transplant, which leaves them more susceptible for infection. So this recipient's heart was fine. No issues with the heart transplant, but the donor lungs he received were positive for Legionella pneumonia. So we're then treating him for that post-transplant. Then we have immunosuppression-related complications. And medications are used to prevent rejection, may lead to side effects such as renal dysfunction, hypertension, and metabolic issues, which would be why we do end up putting them on CRRT, or they are vented for a prolonged period of time. And then organ rejection. The recipient's immune system may recognize the donor's heart as foreign along with the lungs, leading to rejection. So that's why it's important to administer more thymoglobulin to help kill those killer T cells. So it's not the body attacking it, it's killing those cells that attack the infection from that foreign object, which in turns to be the heart and the lungs. Surveillance biopsies help detect and manage rejection. So patient education is huge. Post-transplant education is an ongoing process, and the information provided should be tailored to the individual needs and circumstances of each transplant recipient and patient. Regular follow-up appointments and continued support from the transplant team are crucial for the long-term success and well-being after both a heart and lung transplantation. Patient education includes immunosuppression management, infection prevention, monitoring and follow-up visits, lifestyle modifications, respiratory health, medication education, pulmonary rehab, psychosocial support. Returning to normal activities is huge. Transplant-specific precautions, financial considerations and burdens, and then communication with the healthcare team from here on out. So immunosuppression management is extremely important, and understanding that helps prevent organ rejection. It's adhering to the prescribed medication regimen, including timing and doses of the immunosuppressant, and then monitoring and being aware of those potential side effects that can come with those medications. Infection prevention. It's going to include proper hand hygiene, avoiding sick individuals, and then again, recognizing those signs of infection, and then understanding that you are at increased susceptibility to infections due to how weak your immune system is because of all the medications you're on and the trauma your body just went through. Monitoring and follow-up. It's important to have regular follow-up appointments with the transplant team. Schedule yourself for routine monitoring, including blood tests, imaging studies such as x-rays, and then your pulmonary function tests if it's a lung transplant. And then recognizing, again, potential complications and when you need to seek medical attention. Lifestyle modifications. It's going to come with any big surgery. Dietary recommendations, including a well-balanced diet, and monitoring your salt intake. Guidelines for physical activity and exercise, and taking into accountability what their life and fitness level was pre-transplant, and to get them as close as they can to post-transplant. Sometimes it's not always manageable, so that's where those modifications come into play. Respiratory health, breathing and exercise techniques to help optimize the lung function. And then if you have, any viral infection coming in the winter, like cold and flu season, just be very cognizant of your health and not being around those sick individuals. Medication education. It's detailed information on each one of your prescriptions and including its purpose, like why are you taking it, when you need to take it, what side effects does it have, are you on anything for those side effects, and any interactions, whether it be drug or food related. And then finding a way to manage your medication regimen. Honestly, getting just a box of the week, AM, PM, would most likely be the easiest. Pulmonary rehabilitation. Encouraging to partake in pulmonary rehab, and that'll just help improve your overall respiratory health and as well as your heart health. Brisk walks, walking on inclines. You really want to help improve that cardiovascular health as well. And exercise guidelines for recommendations on incorporating physical activity into your daily life. Movement is important, 30 minutes a day. Psychosocial support is huge. There are a lot of emotional and psychological aspects of having a transplant, and then in the recovery part of that transplant. It's going to be finding counseling to help you, support groups, and mental health resources, because it's not going to be easy. It's going to be difficult. It's going to be slow and steady, and it's going to take time. And then returning to your normal activities. Gradual reintegration into your ADLs or daily activities, work, social life, extracurricular activities. It's all going to take time. But the best way to do it would probably be from guidance from your support systems on specific activities, and following up with your doctors to see when you're ready to do XYZ and if it's an okay time to do XYZ. And then transplant specific precautions. Talk about sun protection, vaccinations, dental care for the heart. You don't want anything endocarditis. You can get an abscess, and then bacteria infection. The bacteria can get into your new heart, etc. And then he was diagnosed with histoplasmosis due to environmental hazards. So just make sure you're taking the necessary precautions to stay away from those. Again, it's unclear on maybe where they lived in Colorado and how he was so susceptible to histoplasmosis and that fungal, but just to be very cognizant to stay away from that same environment. Financial considerations, man, that is a tough one. It is a big one. And that is where the social work and casework and a good insurance steps into play, and finding guidance on navigating insurance coverage, and then understanding those financial aspects of post-transplant care. And hopefully you have a great case social worker to help you through that prior to, and will follow you along post-transplant. And then communication with your healthcare team. That's probably going to be one of the most vital and important aspects of the education. Is if you have any questions whatsoever, contact somebody on your healthcare team. Open communication is the best way to go. And then if you feel that anything has changed with your health, to contact them. Again, here is another beautiful x-ray of our patient, and this is post-extubation. Here we go. I'm going to draw again. As you can see, this right here, we were unable to get off the ventilator for quite some time, so he did require a tracheostomy. So we are working currently with speech-language pathology and a Passy-Muir valve to get him to speak, to swallow, and hopefully week by week by week, we can exchange the trach tube. It'll get smaller, eventually close that up, and he'll be able to go back to his normal life. Here, it looks like we have a triple lumen catheter. Let's see. We have our Dobhoff still. Is this a chest tube? It looks like he still has pleural chest tubes. His incisions here are closing, look nice. Beautiful incision. Actually, they did a great job. His heart's still looking good. Lungs are looking grossly clear. You don't see a lot of congestion. Down here, you can see the points. You can see there's no pleural effusions. Here, you can semi-see his diaphragm. But yeah, he's doing well. It's doing well, but it will take some time. All right, few more slides to go. I hope you're staying with me. We're going to talk about the healthcare system's impact on the plan of care. So most importantly is the availability and access to resources. Does this patient have insurance? Well, like I said, he moved, and he's been on disability for the past 2 years. He moved from Colorado to California to become a resident of California, so then he can then apply to Medi-Cal for insurance. His insurance was accepted for this transplant, and the social workers and financial connoisseurs play a huge role in assisting patients in navigating the financial aspects of this part of their care. Support from the healthcare team members. The healthcare system, at least Cedars, is extremely supportive, and they have great communication and collaboration among all the specialists in the interdisciplinary teams. As I mentioned, many slides back, ensuring a coordinated plan of care. So sometimes these surgeons, these doctors, they do have conflicting opinions. Not that any of them are wrong, just their specialty or their primary concern is more important than another. So that's probably where the back and forth goes, but everything is in the best interest of the patient. There's always like nephro and cardio always going at it, and we should diurese, we should not, we should give more fluid, we should not. So there's that aspect, but I feel that's everywhere. But it's all, again, with the patient's best interests. Healthcare delivery site was Cedars-Sinai Medical Center, and it is a not-for-profit healthcare delivery system. And follow-up care and rehabilitation services. He's going to need physical therapy, occupational therapy, speech, and respiratory therapy. So he's been in the hospital for a little bit over a month, so you can imagine you'd become a little deconditioned and weak. So that's where the physical therapy comes in. Occupational therapy, not so much. I think he should be fine. Maybe he'll have a little bit of neuropathy here and there, or fine motor skills just because he hasn't been moving them, but I think he should be fine. Speech language will be a big one. As you saw on the previous slide, he ended up getting a tracheostomy. So just to get his swallow back, his speech back, his voice, it will take some time. And then with the lung transplant, respiratory therapy and rehabilitation for sure. But Cedars being one of the top hospitals, we have all that access for him and are working with him to go to all these follow-ups once post-discharge. All right, everybody, we made it to our final slide, real-world barriers, and this is pre-transplant and post-transplant. So overcoming these barriers requires a comprehensive and individualized approach involving close collaboration among healthcare professionals, patients, and their families. It's important that the entire process from evaluation to transplantation and recovery can be emotionally and physically demanding for the patient and their support system. The unpredictability of organ availability stresses the need for ongoing communication and readiness. The specific time frame can vary widely, and individual experiences with lung transplantations may differ. It's advisable for the patients to work closely with their transplant team to understand their unique situation and prepare for potential changes and uncertainties associated with the process. Again, as I have mentioned in the previous slides, his issue with his lungs was the donor lung had Legionella. So he also developed Legionella pneumonia from it, which we just treated, which was another complication, set him back a little bit, but he's okay right now. So pre-transplant, donor availability. They have to be the specific size, age, height, weight, all those factors. It depends what number you are on the transplant list, how severe it is. A lot of factors can go into it. Coexisting medical conditions. He had an extensive list of cardiac issues along with pulmonary. Financial and insurance barriers. This one is, there's a lot of people who get turned away because they don't have insurance, and unfortunately not everybody can drop a couple million for a transplant. There are some cases though. Multidisciplinary coordination, and the biggest is a support system. It has broken my heart time and time again where I have seen people be rejected because they don't have a support system post-transplant. And because of the severity of the transplant and recovery, you need that system. So that's why case management and social work is involved so much to make sure that this patient truly, truly has that. Post-transplant, which is histoplasmosis recurrence. Let's hope not. We'll cross our fingers. But in cases where fibrosing mediastinitis is secondary to histoplasmosis, there may be concerns about recurrence of the fungal infection in the transplanted organ, which is why instead of doing one lung, they'll do both. Follow-up care. They may not have transportation. They may stop going to follow-up care. Immunosuppressive therapy. And again, support systems. The sad thing that I learned is that most lung transplants are only viable for 5 to 10 years tops. So they either go through this process again or not, more or less. But thank you so much for listening to my presentation on fibrosing mediastinitis secondary to histoplasmosis. I hope you enjoyed and hope you've learned something. Thanks so much. Have a good one.